And I request Dr. Satish B. Rao, Professor and Head, Department of Medicine, KMC Mangalore, and Dr. Muralidhar Varma, Additional Professor, Department of IFT, KMC Manipal, to chair the session. Over to you, sir.
Good afternoon to all of you. Finally, we are into a very interesting session. In any conference, debate is the most sought after session. So we are in for a treat. We are two young, combative people who are ready to debate a very interesting and hot topic. Just to give an introduction, it is empirical usage of antifungals, fluconazole versus echinocandins for invasive candidiasis. So that is what we are going to debate on. And this is a very, as you all know, very relevant topic, because invasive fungal disease is adds to the mortality and morbidity in any critically ill patient or in any hospitalized patients. And we have not very careful, it has a very profound impact on the outcome of patient care. So then to make it, it is very relevant that we try to do something to prevent it from happening. To that effect, there are many guidelines which are recommending usage of prophylactic antifungals, and it's also part of the antifungal stewardship programs. But then there are a lot of things which are not very clear, right from whether it should be given or not, although it is there in the guidelines. Then if at all we decide to use, which one to use, whether it should be echinocandins or fluconazole or something else, or at what time we should start introducing it. Should we give it early, late? What is the correct timing of introducing the prophylactic agent? And what should we look for? Should we look for 30 days survival or survival at the end of the 7th day or 8th day or something like that? Or what should drive it? Is it based on the risk factor profile of an individual, or it should be some biomarker driven decision? Most of these things are not very clear. Now to debate this, we have Dr. Shivdas, who will be speaking for echinocandins. And then we have Dr. Nias, who will be speaking for fluconazole. So the rules of the game are, first they will be making their presentations, and then there will be time given for quick rebuttal, and then probably we can have a brief question and answer session if there is time. Audience will obviously be involved because debate is driven by the audience always. So before we start the proceedings, I would like to take a note on this question. How many of you would like to go for empirical antifungal therapy in a critically ill patient? How many for or how many against? You can just raise your hand. For you can. Not many. Majority, I think, are for no. The second question is, if at all you decide to give it, which one you would like to give? Fluconazole or echinocandins? Those for fluconazole can raise the hand. Okay. What about echinocandins? Any takers for that? It's sort of 50-50. We'll see how the things change. So without wasting any more time, I welcome Dr. Shivdas to start his presentation.
Thank you, sir. So we'll be seeing what antifungal will start empirically in suspected invasive candidiasis. Okay. So we have three parts. One is echinocandins, and second is invasive candidiasis and empiric therapy. Okay. So first part is echinocandins. As we all know, it is a non-competitive inhibitor of beta-glucan synthesis. What is beta-glucan? It is a molecule which is required for cross-linkage of the cell wall of the fungi. Okay. So this molecule is like a penicillin. It will block the cross-linkage and it will make the cell wall weaker. That's how it causes a disruption in cell wall synthesis, causes the leakage of the cytoplasm and kills the organism. If you look at Candida, the entire cell wall is made of beta-glucan. So it is kind of fungicidal. Whereas for Aspergillus, the beta-glucan synthesis mainly occurs at the tip and the junctions. So it is more of a fungistatic kind of drug. So in our arsenals, as of now, we have 4 antifungals in the echinocandin group: the caspofungin, micafungin, annidulafungin, and risafungin. All 4 have similar spectrum of activity with very minimal changes in the pharmacokinetic and pharmacodynamic properties. Okay. The second was empirical therapy. When we consider empirical therapy, we mean that we are just suspecting patient might have a candidemia. So we look at risk factors. We have a patient who is not responding to our broad spectrum antimicrobial agents. The patient is critical and is at risk of candidemia. Okay. Here we tell that patient will have either invasive candidiasis or a candidemia, and before starting any therapy, we should consider what could be the probable organism, and we should have an idea of our own hospital's drug sensitivity testings. Okay. As Sir has already mentioned, the more delay we start in antifungal therapy, the higher the risk of mortality. So the therapy should be started at the earliest and it should be effective. We should not look at whether the therapy which we are dealing with, the organism can be resistant. So we have trials which have shown that, before going that, so when we think of antifungal therapy in critical patients, we have 3 drugs. One are the echinocandins, second is the amphotericin B, and third would be the azoles. So in my subsequent slides, I'll try to show how echinocandins perform against these. Okay. So the first trial which was conducted was anidulafungin versus fluconazole back in 2007. It was a double-blinded non-inferiority RCT where 255 patients were randomized into anidulafungin group where there were 127 patients and 118 patients in fluconazole group. And all these patients either had candidemia, about 89% of them had candidemia, and the rest had invasive candidiasis. The most common organism which they identified was Candida albicans, glabrata, and parapsilosis. And the endpoint was clinical success with microbiological resolution. So clinical resolution or clinical success is defined as when there is resolution of signs and symptoms because of invasive candidiasis, and once we stop antifungal therapy, there is no residual symptoms. And microbiological success was defined by eradication of Candida species, which was based on the repeated cultures being sterile. Okay. So the results was there were high failure rates in fluconazole group, but they had seen a greater response rate with anidulafungin, especially in the Candida albicans group. And this was later confirmed with the post-hoc analysis by the same authors, which I'll be discussing subsequently. So when we look at the results, we can see that at least in the early part of therapy, up to about 2 weeks, we can see that the response was in favor of anidulafungin. And at 6-week follow-up also, even though there is crossing towards fluconazole, but we can see majority of the response was towards anidulafungin group. Okay. Also, if we see individual pathogen-wise, we can see that for almost all organisms, anidulafungin performed better when compared to the fluconazole group. Okay. The next was caspofungin versus amphotericin B. So there was a double-blind, double-dummy non-inferiority RCT, which comprised of 224 patients, and of which 114 were in Candida group and 125 were in anidulafungin group. The population had either candidemia or they had a candida growing from a sterile site. Okay. And these patients were stratified further according to their Apache score into critical and non-critical, and based on neutropenia, whether they were neutropenic or not. Okay. So the common species they identified was albicans, tropicalis, and glabrata. They also defined overall response and microbiological success, which revealed that Candida was performing better when compared to amphotericin B. And also, as we all know, amphotericin B is relatively toxic, so there were higher incidence of adverse drug reactions in that arm. Okay. Then there was a trial comparing, recently published trial in Lancet comparing micafungin versus liposomal amphotericin B. It was a phase 3 randomized double-blinded RCT, which comprised of 531 patients with 246 in micafungin arm and 267 patients in the liposomal amphotericin arm, and these patients had either candidemia or invasive candidiasis. Okay. The common species were albicans, tropicalis, glabrata, and parapsilosis. These 4 species are common cause of invasive candidiasis in our country as well. Okay. The endpoint was again over treatment success in the form of clinical response and microbiological success. And the results which they revealed was the micafungin performed better compared to liposomal amphotericin B as per the modified intention to treat analysis. And there were fewer side effects in the micafungin arm. Okay. These were the RCTs which compared echinocandins against other antifungals. And we had some other observational and post-hoc analysis done by these authors, which also showed that echinocandins had a better response compared to other groups. Then recently a network analysis, meta-analysis was published, which compared studies from 1996 to date. So they only considered all head-to-head RCTs. They compared between they considered for patients who had candidemia or invasive candidiasis, and they compared with any combination of azoles with echinocandins or amphotericin B. That is, there were trials comparing azoles with amphotericin B. There were trials comparing echinocandins with azoles, echinocandins with amphotericin B, like that. Okay. So they had 12 studies, and the results were overall echinocandin showed a higher success rate when compared to amphotericin B, and azoles were less effective compared to both. So as you can see in this chart, when compared to amphotericin B, echinocandin had a better response rate, whereas azole performance was poor. Okay. So based on all this, 2016 IDSA guideline recommends that in non-neutropenic patients, echinocandins would be recommended as initial therapy when considered empirically. They do not prefer any echinocandins, whereas if patient is non-critical and if there is a chance that fluconazole is resistance is less likely, we can consider fluconazole as an alternative. But still, echinocandins remains the first empirical choice of therapy. For neutropenic patients, for all the more reason that they are on fluconazole prophylactic therapy, echinocandins again remains the drug of choice. And if there is no azole exposure, then we can consider fluconazole. But in neutropenic patient, again, echinocandins cannot be given. We prefer liposomal amphotericin B. Okay. Now, if we consider our patients whom we are treating empirical therapy, they will be hemodynamically unstable. They will be having multiple drugs going on. They can sometimes be post-transplant who may have drug interactions, and they sometimes have renal and hepatic issues. They can have hepatitis or AKI. So in these scenarios, if we see head-to-head, we don't have drug interactions with echinocandins. Echinocandins do not require renal modification. Only for caspofungin, we have dose modification for hepatic dysfunction. Otherwise, rest of the echinocandins do not require any hepatic drug dose modification as well. If we look at adverse drug reactions, we have very little adverse drug reactions. Whereas if we look at fluconazole, hepatitis and QT prolongation is always a concern. Okay. In addition to Candida, there are trials which have revealed that echinocandins also covers PCP and Aspergillus. And as of now, there are few reports of resistance when we look at echinocandins. So with this, I'll conclude, and I would request Niyaz sir to carry on. Thank you.
So when this topic was first told to me, so this was a picture that came into my mind. So we have the humble, small fluconazole, it's the David, and the mighty pharma-backed Goliath. So echinocandins. So my point is that do not underestimate any drug because it's old or has been used for a long time. So this is a drug with maximum experience, excellent oral absorption, not affected by food, high penetration into the CSF, which the echinocandins do not have, and to the ocular fluids. Again, the echinocandins penetrate very poor to the ocular fluids, and the highest level of renal excretion. Less potent inhibitor of CYP3A4. No, so the drug interactions also are not as much as that you see for voriconazole or posaconazole. Shivdas also told about hepatotoxicity, but enzymes do get elevated in some patients, but how many of them are clinically significant? Not much. So my contention is that fluconazole is a cost-effective, reliable, and safe alternative to echinocandins in non-neutropic patients who are hemodynamically stable. This is something that we have already discussed, Shivdas has already shown what the guidelines say. So they've proven candidemia, the treatment of candidemia in non-neutropenic patients. Echinocandins, they say, are the recommended therapy. Fluconazole is an acceptable alternative in selected patients who are not critically ill and who are considered unlikely to have fluconazole-resistant candida. Similarly, in neutropenic patients as well, echinocandins are recommended as an initial therapy. Fluconazole is an alternative therapy for patients who are not critically ill and have no prior azole exposure. And empirical therapy. Empirical therapy, again, echinocandins, they have recommended as a first choice. Now, empirical therapy can be of two. One, you're clinically suspecting of fungal infections, a candida infection, and giving the antifungal. Or second, you have an yeast which has grown in the culture where you have to give an antifungal. Both can be considered as empirical therapy. So the guidelines prefer echinocandin, but they have not completely excluded fluconazole as a treatment for even for empirical therapy of candidiasis. Now this is what Shivdas has already shown you. This trial by Raboli et al. Is the only trial which has compared fluconazole with an echinocandin. That was with anidulafunkin. And you can see that this dotted line on the other side is the non-inferiority margin. And basically what this trial was intended to was to prove that anidulafunkin was non-inferior. And well, I'm arguing again myself, but you can see that it's beyond that zero line, which means that it is showing superiority. Anidulafunkin is showing superiority in patients, like you can see a 2-week follow at the end of therapy, at the end of intravenous therapy, 2-week follow-up. And 6-week follow-up, you don't have that superiority because it has crossed the zero line. So basically at the end of this particular trial, anidulafunkin met the pre-prescribed criteria for non-inferiority fluconazole. But the confidence interval of the difference excluded 0. There was significantly greater response in the anidulafunkin group, suggesting a superiority as well. But when you critically analyze the paper, again, this chart was shown, and when it was said that like anidulafunkin was effective against all the Candida species. But look at Candida parapsilosis. If you look at the global response, 64% of patients with anidulafunkin had responded, but the response was 83% when in the fluconazole group. So you cannot like completely, like based upon this trial, like say that anidulafunkin is effective against all the species of Candida. Especially against parapsilosis, we have this risk of increased MIC with the echinocandins. And this trial also have shown that. Now, why are the trials looking at all these soft endpoints like global cure rate, microbiological cure, and why don't they simply look at mortality if they really believe the drug is superior? And they looked at it, but it was a secondary endpoint. So in the secondary endpoint, unfortunately, there was no significant mortality benefit. Okay, obviously more patients died in the fluconazole arm, but the statistical significance was not there. So this trial, this is the only trial which compared fluconazole with an echinocandin, has not proven a mortality benefit for echinocandins. Now, even if you're looking at the global cure rate, we have to assess other factors. Now, thus a sender effect, because sometimes some of the centers may recruit more patients and which may inadvertently affect the study as such. Now, in this particular study with Raboli et al., which is a main study in favor of anidulafunkin or the echinocandins, if you remove one center, the patients from one center, you can see that this superiority factor actually disappears. So at least you cannot say that anidulafunkin is in fact superior to fluconazole based upon the study by Raboli et al. Alone. We need more data. And adverse effects, fluconazole was said to have more hepatitis. Let us see this study even. So treatment-related adverse events was similar in both fluconazole and anidulafunkin in the same study. So transaminase level was more in fluconazole, but only one of them were clinically significant. Now, if the enzymes rise to 60, 70, or also it's called as transaminitis, but clinically, what is the difference that is going to make for the patient? So I don't think fluconazole has that much of an adverse event as well. Regarding the ad hoc study that was said, which this particular study was done as an ad hoc study based upon the study of Raboli et al., where they looked at patients who were critically ill, severely ill patient also. Even at least in this group, could they prove a mortality benefit? No. All-cause mortality at 28 days was 20.2 versus 24.3. There was no statistical significance. So even in patients who are critically ill, there is no data which have conclusively proven that anidulafungin improves mortality in patients with invasive candidiasis. So micafungin has been, the echinocandins has been compared with other agents as well. So it has been compared with liposomal amphotericin B. So it is comparable to liposomal amphotericin B. It is not superior to amphotericin B. But that has been proven with fluconazole also. So fluconazole has been proven to be comparable with amphotericin with various randomized controlled trials, including neutropenic patients as well as non-neutropenic patients. So none of these trials has proven any superiority of amphotericin B over fluconazole. And again, the echinocandins have not proven their superiority over amphotericin B. So in short, none of these agents have proven a superiority over the others in terms of clinical success or mortality. And in this particular meta-analysis which they did, are echinocandin associated with low mortality. So echinocandins was compared with all the other agents, including the azoles and amphotericin. The only study which has some to the left, which favors echinocandin, is a study by Riboli et al. The rest, all of them is almost in the middle. Which again, in terms of mortality, you can see that it is touching the midline. So a statistically significant mortality still has not been proven. So then there was this particular study, which was a quantitative review of the randomized trials, which said that echinocandin treatment was associated with decreased mortality. So this was published in CID. But this particular study had a selection bias, and the selection bias was again published in the next edition of the CID. So they included 7 studies in this particular study. But only 3 of these studies actually directly compared echinocandins versus fluconazole, but the remaining trial were just studies which included echinocandins alone, or they were comparing the echinocandins in between themselves. Now you know echinocandins are new drugs, so they are used in the new, modern era, where other medical treatment has improved. So you cannot compare studies which has been included the echinocandins alone to studies which were done long back with fluconazole. So 7 studies took place between 1989 and 2006, and echinocandin studies were predominantly conducted in between 1997 and 2006. So advance in recent years demonstrate an increase in survival after fungal infection. But if you're removing the studies which included the echinocandins alone, the mortality rate of patients who received echinocandins and those who received other antifungals, it remains almost the same. So again, this study also fails to prove that echinocandins are superior to fluconazole in the treatment of candidemia. And this was another trial. Now, all of these trials looked at actually proven candidemia, and all of these studies do not look at what was the initial antifungal given. This is after confirmation of candidemia. So up to 48 hours, there was a period given in these clinical trials whether you could use any antifungals. Now, this particular study, that is candidemia in critically ill, initial therapy, what was the initial drug that was used and based upon which there was a mortality benefit or not? This was not an RCT, agreed, but it was a cohort analysis, and they looked at patients who received echinocandins and fluconazole, and they found that 28-day survival was higher among patients who received fluconazole compared to patients who received echinocandins. Now, in some of these patients, antifungals were changed after 2 days. It was allowed. And when they looked at, it was seen that in the fluconazole group, the change of the antifungal occurred the maximum. And it can be argued that it could be due to a treatment failure. But when you look at further, the patient started on fluconazole and switched to another antifungal regimen within 2 days were more likely to survive. Whether it was because fluconazole failed, but that is not the case actually. So among these patients who were initially treated with echinocandin and who had an antifungal change, the 28-day survival was 51%, and which was not different from the patient who were initially treated with echinocandin and continued on echinocandins. In contrast, among 90 patients who were initially treated with fluconazole and therapy was changed, the 28-day survival was 61. And the survival to 28-day among patients who received fluconazole alone for more than 2 days was 68%. So it's not just because the fluconazole was changed to another antifungal, even otherwise there was some mortality benefit, which is seen in this cohort study at least when you compare the initial therapy, that is more important in empirical therapy, I believe, even though it is not an RCT. And finally, the IDSA says, in the same document you can see, despite the overall robust nature of the RCTs that examining the treatment of candidemia and other forms of invasive candidiasis, no single trial has demonstrated a clear superiority of one therapeutic agent over another. So my contention is that you don't have a proof for superiority. So a 48-year-old farmer admitted in your ICU with stroke and is on ventilator. He has a CVC for difficult IV access. He's running fever for the last days, otherwise stable, and he has fever. His blood culture grew yeast and sampled from the CVC and peripheral vein. So what will you do? So how many will choose anidula fungin here? How many will choose fluconazole? Seems to be more. You will have to answer them, Shivdas. And if you are still not convinced, you should also have a look at the cost. The fluconazole of 1 day cost will 191, but caspofungin, the range is around 10,000. You can keep at the middle, 10,000, 10,000, 10,000. For 14 days, it's 1.4 lakhs. The 14 days is after clearance of candidemia. Sometimes it can go more than that. So to summarize, fluconazole is a cost-effective, reliable, and safe alternative to echinocandins in non-neutropenic patients who are hemodynamically stable. Thank you.
So I agree with whatever Niyaz sir said, but having said that, whenever we consider empirical antifungal therapy, we have to look at our own epidemiology also. So in one of the previous presentations, Dr. Sharda has told the resistance patterns of Candida in our country. In some of them, we had seen fluconazole resistance, especially crucii and glabrata. In hospital settings, when we are planning to start empirical therapy, we think of hospital-acquired Candida, and this should always be kept in our mind. So unless we have a proof that we are dealing with a sensitive organism, I would still feel echinocandin to be initiating and then step down according to the sensitivity or response, whatever we get. So I would still feel echinocandin should be started and then early step down as per sensitivity.
I do agree with Shivdas that there is an increasing resistance in Canada to the azole group, which is increasing. So again, but what I was saying is that in a group of patients who are hemodynamically stable and non-neutropenic, they can afford, we can afford to give fluconazole for a few days. Even if the resistance, if later detected, we can change the therapy. This is predominantly based upon a cost analysis, considering the patients who come to our hospital, and 10,000 rupees per day is not going to be tolerable or affordable by most of our patients. So in a patient who is otherwise stable, like a central line associated candidemia, which can even sometimes be cured by removal of the central line, waiting a few days on fluconazole for the susceptibility report, I don't think is going to affect the mortality of the patient. I'm not arguing against the echinocandins. Nobody should go with that as understanding. Echinocandins definitely has a role in the treatment of candidemia in patients who are hemodynamically stable. Definitely, echinocandins will be my first choice as well. But it is not that all drugs have to be completely avoided from the treatment guidelines. In a select group of patients, if you can clinically assess them and you've confident about their clinical status, fluconazole is still a reasonable alternative to echinocandins in such patients.
Thank you, Dr. Niyaz. I think what we will do is we'll take the poll again and see whether there's a change in mind of people who said for echinocandins. So how many are for echinocandins for empirical antifungal? Shivdas, you have to sort of, this election year, I think you have to promote your topic, right? Anyhow, thank you, Niyaz and Shivdas. The important thing for us to understand is, I think there is absolutely no doubt in neutropenic patients what to give. I think there should not be any debate. ICU patients, especially medical ICUs, we may not see only neutropenic patients. So in non-neutropenic patients, is there any role of fluconazole? I think it's important to understand what is a local antifungal sensitivity. Like in our hospital, we don't have much of resistance. And if you look at our hospital, cost is a big bearing for us. We are not a corporate hospital. Definitely there's a role of fluconazole because we have scheme patients, etc. I think all these considerations are important apart from the what is the science behind it. If you look at PKPD studies, etc., definitely echinocandins have far better effect compared to fluconazole. I think that is the message is very important. And other important thing, I think both of them agreed, even though they were trying to debate each other, is how stable is your patient. In the case which he was trying to show, when patient is stable, I think starting fluconazole is all right, right? But once patient is having multi-organ dysfunction, somebody has a septic shock, probably you're taking a too much risk for the first 48 hours before you get your cultures and sensitivity, even though your fluconazole resistance are very low, like in our center. I think that is a message which has to be told. Yeah. Thank you very much.
I thank the speakers for the thought-provoking discussion, and I also thank Dr. Satish B. Rao and Muralidhar Varma for chairing this session. Moving on to the next session, we have panel discussion. To moderate the session and introduce the panelist, I invite Dr. Praveen Tirlangi. Over to you, sir.
Very good evening. I should congratulate you all for staying back till this time and being enthusiastic of learning something new. So I am very sure that all the sessions have went very well. So we are having a good panel discussion. It will be basically the summary of what you have learned today since morning till now. So I would like to invite our experts in different fields. So we'll have a ID physician, Dr. Muralidhar Varma, sir, to chair the session. He is the head of the unit, Infectious department here in KMC Manipal. Then I would like to invite Dr. Ravindra Prabhu, sir, Professor, Department of Nephrology. Dr. Sharada Vinod, she is DM, Pulmonary Critical Care Physician. And Dr. Swethapriya ma'am is a professor, head of the department, Critical Care. So basically we have a very esteemed panel from different departments. You can see a nephrologist sitting here. Then you can see an ID physician. You can see a critical care physician. And you can see a pulmonary critical care physician. So we want them to fight among themselves so that we can learn something today. And I would like the panelists to be very frank and give their opinions. Again, science is always about questioning. So whatever is being told, said, you always have to go back and read and know what is right and what is wrong, and you should always come back with questions. So I'm expecting some of the questions to be asked at the end of this session. And I'm a moderator, I'm not a panelist, so I will not be answering any questions. My job is to just ask questions. Yeah, that is an easier thing. So when the patient comes to emergency, he will not tell that I'm a patient of infectious disease or I'm a patient of critical care. So when the patients comes to emergency, they are sick, they actually require a multidisciplinary care. One patient comes with pneumonia, subsequently develops AK, then a nephrologist has to dialyze him. So it is very important for the physicians from different departments to come together and take a call on what to do in the particular patient. So you cannot really say that I'm ID physician, I have no job to do with a person's AK. So it is important to have a basic knowledge of all the departments. So we will try to do that in next panel discussion. So let us see one critical ill patient. He's a 67-year-old smoker. He doesn't have any other comorbidities. Presented with 5 days history of fever, cough, and 3 days history of progressive shortness of breath, then decreased urine output for the past 1 day. You don't have any details of what treatment he has taken, but he took some over-the-counter medication with no improvement. Now we presented to emergency. He's very tachycardic, heart rate is around 120, lot of sympathetic overactivity. With that, his BP is 90/60. Lactates are high, at least 3 times the normal. Urine output is very borderline, 10 to 15 ml per hour, and creatinine are already rise. It is 3.4. He is febrile. His saturations are hovering around 88% despite putting him on 5 liters of oxygen, and he's very tachypneic. The respiratory rate is around 35. You got an ABC that is showing metabolic acidosis, high anion gap metabolic acidosis with severe hypoxia. Basically, he's in type 1 respiratory failure. And this is the X-ray, which is showing kind of low bar pneumonia, right lower zone. So what could be the etiology of this condition, and why do you think it is the etiology? So I direct this question to all the panelists. You can give your opinion. So is it bacterial, viral, fungal, parasitic, and what do you think?
This definitely looks like infection to me because there is history of fever and cough and also a smoker. But we also can't rule out cardiac involvement in this patient. Along with infection, he might have a cardiac involvement also. So it's important to evaluate for other causes also, for sure.
I mean, I concur. And do you want me to speak on this? Or so, since he is a chronic obstructive pulmonary disease, most likely, since he's a smoker, 67-year-old, has come with this kind of a presentation, I would put bacterial first and viral would be second. When I looked at the X-ray, I thought that it was bilateral lower zone infiltrates. So I would still keep viral as a possibility, especially if considering seasonal change, I would keep influenza as a possibility for these kind of patients. And in our country, I would keep mycobacterial infection lower down, but as one of the contenders in a patient who comes like this way to us. So in non-infective, like ma'am already said, that we have to look at cardiac function, of course, but it's infective more profoundly right now for me. Thanks.
So it's a rapid progression of a lung problem. It's an infection, most probably bacterial, looking at the X-ray, and the patient is going in for septic shock and acute kidney injury. It looks like a stage 3 acute kidney injury. He'll go in for that. So that's the thing. Most probably in our setting, I would put it as bacterial only.
Yeah, like in ID, we always start first thing, what is a syndromic diagnosis? Like syndromic diagnosis, absolutely no doubt. This is an infection of a lung. The next question you ask is it a severe form of infection? Yes, because patient has organ dysfunction, patient has hypotension. The third one you ask yourself is, what is a likely etiology so that your empirical drugs can be appropriate? So you keep seeing patients from community acquired lung infections, significant portion of them can be viral. Just based on an X-ray and based on history, sometimes it is difficult to differentiate. And many times we found out that patients do have a viral infection which is followed by bacterial. At this junction, I would say viral and definitely bacterial both. Can't swear and say because the patient is sick, so empirical therapy should cover both according to me.
So given that this patient has a multi-organ dysfunction, a very short history, presenting with shock and AK, do you think viral will be the first possibility, or you
Still
say
bacterial
it is most
will be
likely
first.
bacterial? Yeah.
Bacterial will be first,
Yeah.
but still we
So
we should
let
be
us
sure.
think that this patient has a bacterial infection. This is for the ease, I have put some symbols. That blue symbol is you, sir, Varma, sir. So for the ease, can you just answer these questions for our audience? Do you want to give an anti-pseudomonal coverage, MRSA coverage in this patient? What should be your empirical antibiotic therapy given the patient is very sick? Do you want to choose piptaz over meropenem? And if you are choosing piptaz, how to choose? And I think we have discussed a lot about renal modification of antibiotics, but how will you renal modify this patient with a AKN stage 3, as Ravindra Prabhu sir said? Can you answer this question, sir?
Yeah.
For our audience, yeah.
So I will not answer all, some I'll pass it on to Ravindra Prabhu sir. So the first thing, as I said, the temporal profile is definitely suggestive of bacterial infection. For the ease of discussion, we'll keep it like that. At the same time, we have to be careful that we have to test for virus. The first thing is, do we need anti-pseudomonal cover? So when you look at empirical anti-pseudomonal cover, here we are looking at a lung. A normally structured lung, the possibility of pseudomonal infection is very low. But here we are looking at most probably COPD. We don't know, this patient might be having bronchiectasis. In those setups, probably there's a small role of anti-pseudomonal cover. Saying that, this patient, remember, is very sick. He has AKI, he has hypotension. So definitely we have to go for carbapenems. In this setup, especially when we have seen that the community acquired, what we teach for undergraduates now and what we are teaching in hospital acquired, the whole margin is becoming very blur, right? We have seen a lot of ESBLs being grown from the, even we have conducted a study about 15 years back. That time itself, our ESBL rates in the community was more than 26%. So in this patient, definitely we should give carbapenem over piptazole since the patient is very sick and we don't have cultures. Second thing is MRSA cover. Whatever information Praveen has given, I don't find any risk factors for MRSA. Right? So covering MRSA in this patient may not be required because unless we have some additional information. And what is the dose of piptazole, and that probably I'll pass it on to Ravindra Prabhu sir.
So given this scenario, the patient is deteriorating rapidly and there's a chance of mortality. So I think first I will call the infectious disease consult. So if he says, I think I would prefer to give meropenem. Loading dose, as has been told, remains the same. It needs a dose modification, and I would say that 500 mg 12th hourly, but some people would go for higher dose, maybe 1 gram BD, maybe. Because I would say that GFR is 0. If you take the urine output is very less, it's oliguric, it's going to a GFR which is going below 20 ml, or it may be even 0. We need to modify it for that dose. Between the two, I always prefer the carbapenems in this situation.
So we actually had a very good session on how to renal modify the antibiotic doses. I have a subsequent question on the same, but I will just clarify it. See, the clearance of the drug will depend upon the urine output. So if someone is not oligouric, for example, one of the question was when the patient's AK is improving, should we renal modify? We shouldn't, because there is urine going on and the drug will be excreted in the urine. But if you have patients with decreased urine output, whether we should be doing a full dose of antibiotic for the first 48 hours, subsequently we should come down or not, the clinical data is not yet available. You can do whatever you want, nothing is wrong. So coming to the next question, this patient is in shock. And you know, the heart rate was 120, his tachycardia is there, borderline BP, very borderline BP. So the first thing which we do in any patient with shock is giving fluids. Now there is a lot of fight among critical care physicians that how much fluid we should do. So the simple thing is, if emergency physician gives a bolus of fluid, you go and say we will have a restrictive strategy. If they give less number of fluids, you go and see that you have not given enough fluids. That's the way patient has deteriorated. This keeps on happening. There are a lot of fights on the floor. Now I want to know from our expert panelists, what do you choose, like a restrictive fluid strategy or liberal, or and even vasopressors? When will you start a first dose of vasopressor? When are you going to add vasopressin on top of that? So
so with respect to patients in shock, I feel that, you know, it cannot be one single thing that takes, you know, you can't make a decision just based on one thing ever. So with respect to the fluids, restrictive versus liberal, now considering this patient who is a chronic smoker, who has come with septic shock, we assume that it is septic shock, but we also know that there could be a possibility of a cardiogenic shock, either a right ventricular or a left ventricular failure. So the strategy would be to give, and as per surviving sepsis guidelines, it is 30 ml per kg in the first few hours is what has been mentioned. So, and then they also go on to say that you give like 500 ml bolus and then you wait and see how the patient is recovering, how is the cardiac function, and then you take a call further subsequently. So I would do that. I would give fluids, and I would for sure have a POCUS, which I do initially for the patient. Look at the IVC, look at the LV contractility, look at the RV size, look at B lines in the lungs, and also use that to give fluids to the patients. So it would be an ultrasound guided, B-line guided fluid strategy for the patient, and not just a restrictive versus liberal, you know, blindly. In addition, after this, in case suppose the patient is not improving after giving IV fluids, then I would consider giving vasopressors. Vasopressors, again, whether it is norepinephrine versus vasopressin, that depends on what is the patient's condition. If the patient has a chance of having arrhythmias or there is an arrhythmogenic potential, the chances of, I mean, it's probably better to use a lower dose of vasopressin than using norepinephrine. Or you may add vasopressin earlier to norepinephrine, and once that happens, then we may consider glucocorticoids as a third line rather than doing it upfront like before. So that's what I feel is to be done for these patients.
Yeah, the surviving sepsis guidelines recommend using 30 ml per kg of fluid of bolus in the beginning, but this again doesn't fit all the patients. So we have to look at the sepsis, source of sepsis, the reason why the patients are presented to the hospitals. They would have been already treated outside in some other hospital, and later on they would have presented to us. So this has to be individualized, but definitely, yes, I would give a bolus of fluid in the beginning and then follow the dynamic indices of fluid responsiveness, see whether the patient is preload responsive or not, and based on that, further boluses of fluid I will decide on. And to use a vasopressors, I would probably wait for about an hour or so after giving fluid boluses. If the blood pressure is not picking up, if the perfusion is not improving, lactate is not coming down, then I would start the vasopressor. And what is recommended is usually to start norepinephrine. So I would start norepinephrine, and if the dose is going up, I would wait till the patient is on about 5 to 10 ml of norepinephrine per hour. And then I would add on a second vasopressor, that is vasopressin.
Okay, so this looks like more of an individualized way of management. Probably asking restrictive versus liberal fluid strategy itself is wrong. So, so the problem with most of us is we don't know how to individualize the fluid strategy, which requires a lot of skills, which we have to learn bedside, which we learn after our panel discussion is over, okay? So this patient also had AK. Sir, you have said that this patient is probably landing up in multi-organ dysfunction and sepsis and AK. But sometimes we keep hearing bedside that this could be drug-induced interstitial nephritis, which is very common with all the beta-lactams which we use. So when should we think of possibility of interstitial nephritis in a patient? Or when should we think that it is just sepsis which is worsening the AK?
So in this situation, the drug is not yet started. So we cannot think of a drug-induced interstitial nephritis. But the situation is like it's a hemodynamic. The BP is low and urine output has come down. So it is like a pre-renal going into an ischemic acute tubular necrosis. That is, once the ischemic acute tubular necrosis sets in, giving the fluid will not change the AK. You have to wait for the kidney necrosis to recover, which takes about 10 to 14 days. The acute interstitial nephritis is a situation which comes once you start the medication, and it's an allergic type of phenomenon. Of course, in some of the infections, classically like leptospirosis or scrub typhus, those can themselves cause interstitial nephritis. So infection and sepsis itself can cause, but classically we see with drugs which are very commonly used, like for example, you give diuretics or the proton pump inhibitors, some of the antibiotics like penicillin group of antibiotics, or means any of the antibiotics can cause, but these are the common ones which we see, and usually it affects the interstitium. So you would expect some urine to be there in that situation. It's not a glomerular problem. So just to recapitulate, the kidney means it is either glomerulus, tubule, interstitium, or blood vessels. So this is a compartment where interstitium is affected, so the concentration will be affected. So we expect some urine to be there, and once the kidney goes into severe renal failure, that's the time the output will come down. Here, this is a situation where the output has come down first, then the creatinine starts going up. So it's like a ischemic ATN. That's a reverse situation in AIN, and the way to diagnose it is there will be pus cells in the urine. So you get a culture negative. You get WBCs in the urine, WBC casts will be there in the urine, and of course it's a pathological diagnosis. You have to do a biopsy for that.
Yes.
What you asked about the drug-induced is like that. Yeah. And one more thing is, very rarely the classical signs of rash, eosinophilia, fever, which we describe for any allergic thing will be there. That is seen in only 10% of the patients.
Thank you, sir. So basically it is also important, especially when the patient gives a history of drug intake before, to consider a possibility, keep a possibility of drug-induced interstitial nephritis, because most of the times they are labeled as pyelonephritis, culture negative, because there are pus cells, patient is spiking fever, but patient will be otherwise hemodynamically stable. So there are some clues, and again one has to remember that if you have non-oliguric renal failure, the antibiotic drug modification becomes a little bit tricky, because the patient is pouring urine, the drug will go in the urine. So it is about the drug clearance which we are looking at. So if you are having probably non-oliguric renal failure, you should not be modifying the dose of antibiotics. This patient looks very hypoxic, very tachypneic, with a respiratory rate of 35. PaO2 has gone down below 60. Bilateral lung infiltrates. So how are we going to oxygenate or ventilate this patient? At this point of time, do you want to consider HFNC as a possibility? Or do you want to go for a non-invasive ventilation or upfront tube this patient?
This patient has a blood pressure of 90/60, so not severely hypertensive. And respiratory rate is, of course, high, about 35 per minute, and is severely hypoxemic. But I would definitely give a trial of NIV for about an hour and see how the patient is responding. If the respiratory rate is settling down, tachycardia is settling down, blood pressure is improving, and the consciousness is maintained, GCS is okay, then I would probably continue it for some more time and then see how the patient is responding. But within an hour, if the patient is not showing any improvement in his clinical status, the respiratory rate not settling down, the hemodynamics not improving, or clinically not feeling better, GCS is worsening, then I would directly go ahead and intubate this patient. And if I put the patient on NIV, I would definitely like to reassess the patient. Initially, at 30 minutes, I would get an ABG done, see how the parameters are. And again, at the end of 1 hour, see if the parameters are improving on the ABG. Probably I would wait for some more time to see whether the patient is responding, doing better on NIV or not. Otherwise, I would directly put the patient on mechanical ventilation. Coming to HFNC, I would prefer to go for NIV because I would like to give some amount of positive pressure ventilation to this patient. So HFNC might not be a very good option. So NIV, definitely, yes, I would try for an hour or so and then see.
I'll slightly differ with ma'am on this.
Let me guess, you'll tube him.
If the patient did not have this kind of metabolic acidosis, I would have been okay with non-invasive ventilation or maybe even HFNC. But with metabolic acidosis, I would prefer to intubate the patient upfront. And maybe after half an hour do an ABG, half an hour to 1 hour do an ABG and see how the patient is responding.
So basically, you can, the important point is if you're planning to put the patient on NIV, it is very, very important to monitor every hour. If the patient is deteriorating, you have to keep a very low threshold. Now that this patient is very sympathetic, there is a lot of sympathetic surge, patient is tachycardic, BP is like borderline. And for example, the patient was kept on NIV and he failed NIV. Now you want to intubate. With this kind of acidosis and the borderline BP, with a very high sympathetic activity, how are we going to intubate? I feel that the moment you put some positive pressure ventilation or give sedation, this patient is going to crash and is going to have a peri-intubation arrest. So how do we intubate such patients, ma'am? Again for you.
So yes, as you said, since this patient is severely acidotic and is having a high sympathetic drive, once we give the anesthetic agents for intubation and give the paralyzing agent, definitely his blood pressure is going to crash. Anyway, we would have started fluid resuscitating this patient. So fluid resuscitation is ongoing. And also I will keep the noradrenaline ready, or I would have already started noradrenaline for this patient, anticipating again drop in blood pressure further. And I will probably use a small dose of ketamine and also fentanyl, and if required, midazolam as well, 1 mg of midazolam, and use rocuronium, and I would intubate this patient. And I'll be prepared if required, if the hypertension is very severe post-intubation, I would give fluid boluses again, and also go up on the dose of noradrenaline, and also start vasopressin if required.
As a pulmonology perspective, I'll just add to this by saying that since the patient has underlying COPD and we are intubating, and if there is sudden worsening of shock, I would again go back to doing a POCUS, make sure that there is no new onset of pneumothorax once positive pressure ventilation has started. And of course, the rest of the things, as ma'am said. And we think of sepsis-induced glucocorticoid insufficiency also.
Yeah, so the key is anticipation. If you are not anticipating a possible peri-intubation arrest, patient is going to arrest. If you think about this is the possibility, then you will make multiple strategies where people will have different ways of dealing with it, and nothing is wrong. Now that we have intubated, now there is one study which says that if the patient has a recruitable lung, if you give low PEEP, patient will die. If the patient doesn't have recruitable lung, and if you give high PEEP, then the patient will have adverse outcomes. So basically, you have to individualize the positive pressure for each patient. So how do we actually assess this recruitability of the lung in your practice when you are intubating a patient? How do you know whether this particular lung is recruitable? Should we be going for a higher PEEP strategy, or should we start with low because the patient is hemodynamically unstable? How do you deal with such situation?
The patient population that I would generally see is those people who have some sort of primary lung disorder. Suppose we have a patient who has an interstitial lung disease and advanced fibrosis, then I do not expect those lungs to be recruitable. Whereas if otherwise the lung is doing okay, I would still need to intubate the patient, and then when the patient is well sedated and paralyzed, then take a look at the stress index during in a volume time curve and see if that patient is having a lung which is recruitable. If it is upwardly concave, you don't expect the lung to be recruitable with that sort of a stress index. And then if recruitability is there, then we'll have to, give the PEEP recruitment measures. The staircase recruitment does not really work, was found to have increased mortality in the ART trial. So we may just have to give a elevated PEEP for a few seconds and then anticipate a hemodynamic compromise which happens at that point of time, and then proceed to an open lung ventilation, keeping a PEEP plat of less than 30 to 35 at the max. Give a chance for permissive hypercapnia.
Ma'am, can you just summarize what is this lung protective ventilation for our audience?
Yeah. By lung many a times what happens is the initiation of mechanical ventilation itself can result in lung injury, which is termed as the ventilator-induced lung injury. So to avoid that, the mechanisms that have been proposed are to use low tidal volume ventilation of 4 to 8 ml per kg of tidal volume, which is calculated as per the ideal body weight, and to keep the plateau pressure less than 30 centimeters of water, and the driving pressure of less than 13 to 15 centimeters of water. Driving pressure is the difference between the plateau pressure and the PEEP. And also now the term that is becoming popular is the mechanical power. So, but it is very complicated. So most of the physicians recommend going ahead with the calculation of the difference between the plateau pressure and the PEEP, and you tailor your ventilatory settings accordingly.
Sir, this patient is having AKI and his respiratory rate is quite high. So many times we write a consult for dialysis, then there is a discussion that early dialysis is as good as late dialysis. Probably you can delay the dialysis if the urine output is good or if the patient is not in fluid overload. How late is late, sir? Like when should we be, this patient is bicarb 10 and one of the reason for his tachypnea is acidosis. And acidosis causing tachypnea can cause lung injury. So a patient with lung injury, I'm very worried about his tachypnea also. So when should we be dialyzing? Should we be delaying it or should we immediately dialyze in such patients?
So as you yourself told, it should be individualized. So there are some indications which everybody will agree on. Those are like emergency or life-threatening. So if patient is having hyperkalemia, no urine output, severe hyperkalemia. Hyperkalemia is causing ECG changes. So anything more than 6 and there is ECG changes have started occurring, we need to dialyze immediately. If there is just less than 6, you could wait for 4 to 5 hours. Or if there is a pulmonary edema not responding to diuretics, that situation we need to dialyze. And then acidosis, metabolic acidosis, the pH is less than 7.2. Bicarb is less than 15 or it is causing a hypotension. So those are the 3 indications where we need to do it on an emergency basis. Then of course there's a concept that is like multi-organ support therapy. There is indications based on the kidney indications. We need 2 indications to dialyze immediately. So patient is having oliguria plus hyperkalemia or oliguria pulmonary edema, oliguria and acidosis. 2 indications are there, you dialyze immediately. If it's only a single indication, we wait, we can treat it medically, it's not working out, medical treatment is not working out. We can then do the dialysis after 4 to 6 hours, but we should not wait for more than 4 to 6 hours in that indication. Now early versus late, again it's a kind of debate and there are multiple studies. Most of the studies say that it's equal or late is better. What is the meaning of late? Whether you do it within 6 hours of diagnosis or after 72 hours, or you can target blood urea, like they use blood urea nitrogen of some people say 40, some studies are saying 80, some wait till 100. So that's what we mean. If it crosses 100, and 100 means it's approximately 200 urea, 1 of 100 means approximately 200. So you wait for that to cross. So if you are waiting for numbers, then we take urea of more than 180 and creatinine of more than 10. But most of these people will have some indication like hyperkalemia, pulmonary edema or metabolic acidosis, the classic indications, and then encephalopathy, pericarditis, those kind of things.
Many of these patients, after the session of dialysis, they will have a worsening of blood pressure again, and our residents land up in escalating antibiotics. So how to avoid this hypotension during dialysis, especially if the patient is in septic shock? Sometimes people say you avoid giving feeds, but RT feeds are very random, like every 2 hourly people get RT feeds. So should we be like stopping RT feeds before HD? Or do you have any other ways of preventing hypotension during HD? Should we infuse albumin? And especially in hyponatremic patients, how do we prevent hypotension?
So usually the dialysis, if you are not removing the fluid, it should not cause a hypotension. What happens is the start of dialysis is actually coinciding with the septic shock.
Yes.
So first the urine output falls, you take a decision to dialyze. When you when you are just about to start, that's the time the septic shock is setting in. That's the gap between that, and that's the coincidence actually. To avoid the hypotension, it's again an individual basis of management. One is you can prophylactically start the noradrenaline, and if the patient is already on noradrenaline, you can increase it by about 20%. And if you have to remove the fluid, you can split the dialysis into dialysis and ultrafiltration. If you're doing for example, if the patient is just having pulmonary edema, you want to just remove the fluid, you can do isolated ultrafiltration. In the isolated ultrafiltration, chances of blood pressure falling are not that much as if you are doing a hemodialysis. You can split it like that, or you can do an extended dialysis. What fluid you are going to remove, you can remove it over double the time. Intermittent means 4 to 6 hours. You can make it 6 to 12 hours. Of course, again, it depends upon availability of machine and all those things.
Yeah. So finally, the ID part. So this patient grew pneumococcus in blood. So I would like to direct this question to Varma sir. So what is the expected outcome of patients with pneumococcus bacteremia, and what is the treatment which we are going to change at this point of time if has received meropenem, for example?
Yeah, again, I think there is no direct answer for this. So we are assuming this patient is in Manipal, right? With that context, I will tell. We have a critical care, we have nephrologists, we also have pulmonologists. So in that context, even in the best of centers, somebody coming with a septic shock in pneumococcus, the mortality is quite high. Remember, this patient presented with shock to our hospital. So it can range up to 20 to 40% or so. That bad it could be. So second thing is, can we change anything right now? Right. So again, remember, this patient is hemodynamically unstable. He is very sick. So in this context, probably irrespective of what the culture comes, probably will continue the same antibiotic. The second important thing is there any role of steroid? Which is again, there are a lot of 3-4 big RCTs which have come in the last 3-4 years. Again, I think the role of steroid is the timing. What time he has presented to us and how stable he is. These two factors have to be accounted for. The patient has presented in what data you have given me. I doubt at that junction giving a dose of what the clinical trials. I think most of the studies have looked at 40 mg methylprednisolone. I doubt. Most of the time we end up giving septic shock dose, right? So probably this patient is quite late in the day to give that dose of steroid because he's come on 5th day of the disease or 6th day, right? So I will not at present change anything. And renal dose modification, depending upon whether the nephrologists decide what type of dialysis. I think we had a detailed discussion on that.
Yeah. Sharada ma'am, like, are you using routine steroids for severe community acquired pneumonia in your practice? Not yet. Okay. So this nutritional part is like this whole holds true for all the departments. So how are you going to feed this patient? That is very, very important, I feel somehow. So I want to take all of your opinions, especially with the patient with AK. Are we going to change something, or we will give a routine feeds like what we do, or are you using restrictive feeding strategy in your practice?
So for this patient, there would be multiple things, like you said. One is the renal limitation. It depends on if there is a reduction in urine output. Also, if the patient is getting adequately dialyzed and the intake output is okay, there is no real reason, in my opinion, of course, sir would give us a better idea on that, for reducing or giving a restrictive amount of feed if the urine output is doing okay and we are dialyzing regularly. and if there is a requirement for dialysis, that is. With respect to hypocaloric versus trophic versus full feeds, that question, one thing which is important is what was the baseline of the patient. If the patient had been maybe not eating too well for a very long time, was malnourished, came to us, then we would have to do a stepwise reintroduction, and we have to then look for refeeding syndrome all the more. Whereas the patient was otherwise healthy, doing okay, not having any other comorbidities, then we give him, since sepsis is also a hypermetabolic state, we need to give adequate nutrition to the person and not reduce the calorie for the person when you're giving feeds at that time. But initially you need to give a smaller amount of feeds by RT just to see what the acceptance, enteral acceptance is, and if the patient is doing okay, then there is a question whether you should give boluses versus the continuous feed. Some ICUs wish to just give bolus feed, some have done better with giving continuous feeds for the patients with less amount of aspiration risk seen in those patients. And subsequently, if there are comorbidities like diabetes, we'll need to account for that when we give the patient feeds. Restrictive feeding has only been, when I've had to use it in the ICU, it's only been for those patients who are anuric and on dialysis. Then we have to take care of the intake, and that will also include the RT feeds that we are giving. With respect to how do we assess for refeeding syndrome, we have to keep a very close eye on all the, levels of your calcium, phosphate, magnesium, and look for worsening weakness, proximal myopathies, loss of DTRs, increasing ventilatory requirements, which would tell you that the patient is probably having refeeding syndrome. So that's my approach.
I would wait for the initial fluid resuscitation to be over, and once a patient is hemodynamically sort of stabilized, only then I would start the patient. Start with a low rate of say 8 to 10 ml of feed of kilocalories per kg per day, and then over a period of 3 to 5 days we can gradually increase it to the target goal of 25 to 30 kilocalories per kg per day. So that's how I would do. And if the patient is still requiring a high dose of inotropes, then I would go with trophic feeds, where I will give feed at the rate of 30 to 50 ml per hour. And once the hemodynamics get better, then I would slowly increase the rate of infusion. And for refeeding syndrome, we have to have a high index of suspicion in patients, especially those patients who are undernourished, who have been kept NPO for a long time, have not been fed for a long time, or patients who are already malnourished. So have a high index of suspicion, and if there is any worsening in the condition of the patient, we have to monitor electrolytes regularly in these patients when we start them on feeds. Start with the low rate and then gradually increase over a period of time. And also monitor the electrolytes if there is a worsening in the patient's condition after starting the feeds.
Sir, as usual, this patient after day 7 had a new onset fevers with leukocytosis, and there is some increased oxygen requirement. So what is this? Can we call it as a ventilator-associated pneumonia, or is it a ventilator-induced lung injury or pulmonary edema embolism? How do we approach this case, sir? This is for everyone. Like, we never see people getting diagnosed with ventilator-induced lung injury, but I'm very sure that is pretty much common. And how do you diagnose a case of VAP, basically? How do we exclude everything else?
Yeah, I will give a little bit different answer for it. Remember, VAPs, when we diagnose, for surveillance, the definitions are completely different because our aim is different. For a clinical point of view, when I go and see patient, this will fit into my VAP, even though I might consider a differential diagnosis. It could be simply worsening of the lung injury directly to the ventilator, or it could be drug induced. There could be multiple differential diagnoses for this. If given the clinical situation, if you are asking me whether you want to treat for VAP, yes, I will treat. Whether it meets the definition is a different question. I think that difference for all hospital-acquired infection should be very clear. Because when we make a diagnosis of hospital-acquired infections, our aim is to prevention. That is where definitions are a little bit different. But for a clinical standpoint of view, this will fit into it. The other ones, probably the definition, the critical care and pulmonologist can answer.
Yeah, this probably fits into VAP as Sir said. But also what we have to remember is ventilator-induced lung injury is underdiagnosed most of the times.
Yeah.
It's very difficult to differentiate ventilator-induced lung injury from worsening of lung because of the infection. But have a high index of suspicion. If you're already following lung protective ventilation strategies, then I would consider it more as infection than VILI.
Considering it is a possible VAP, ma'am, what would be your empirical choice of antibiotics in this patient?
In our setting,
Yeah.
most likely organisms are either Acinetobacter or Klebsiella. So if the patient is already on meropenem, I would probably continue with meropenem and also add on polymyxin B. And also I would consult the ID. So I would go by their opinion. And also maybe if the patient is not improving, maybe consider adding tigecycline. And before that, I would also repeat endotracheal culture if it has already not been sent.
Yours?
Nothing very different.
A consulting ID part or? Yeah.
I'll call you first.
Sir. So
Yeah.
basically VAP.
I think this is what Praveen is trying to ask is summary of all the things what has happened since morning
Yeah.
or last probably 2 weeks, right, for all the antibiotic course. And he's expect me to tell in 30 seconds or minute, right? Again, we have to understand that when we treat VAPs, having a local antibiogram becomes very important. In our hospital, I follow simple rule 30-30-30. In our hospital, Acinetobacter accounts to 28 to 30% of our respiratory cultures, around 22 to 25% of Klebsiella, and around 18 to 15% of E. coli, and very small percentage by Pseudomonas, and even smaller by MRSA. That is how our respiratory cultures in our hospital are. So considering that, obviously I need to cover Acinetobacter. So my choices is given me the choices. Probably polymyxin along with high dose tigecycline is at present an option, or polymyxin with ceftazidime avibactam is these two choices. So how do I choose both of them? I think again I'm telling you what we practice here may not be applicable. Again, we have a lot of scheme patients, etc. That will be one of my driver to see what do I start.
So basically in critical ill patients, somehow in empirical therapy, at least we are not able to avoid polymyxin. But again, this is a complaint, sir. Your resident will come, Ravindra Prabhu, sir. Your resident will come and he will write avoid nephrotoxic drugs. So how do I do that, avoiding nephrotoxic drug when you have polymyxin?
Oh, the life comes first, then kidney. Because kidney you can anyway survive on some amount of dialysis. So if that is the only medication, I think you can modify the dose and give it. Basically, aminoglycosides we try to avoid as much as possible, but even that we have given, because if the patient is dying and that is the drug which is to be used, we can use it. But to the extent possible, it's always a judgment you have to take.
Yes. I think this we have discussed when we suspect a possible fungal pneumonia. So when is the patient ready for weaning? He is a case of community-acquired pneumonia, got VAP, received polymyxin, some amount of critical illness neuromyopathy. So how do we know like this patient is ready for, should we like look at him, he's doing okay, remove the tube or see some parameters? What to monitor before thinking that the patient is probably ready for weaning?
So for weaning, when we even look at daily, every day we have to assess the person for readiness for weaning. In that, the first and most important thing is that the reason for which the patient got intubated has to not be there any longer. Once that is taken care of, then we can say that, okay, the FiO2 of less than 0.4, PEEP of less than 5, patient has good neck holding, good clearance of secretions, is able to move, understand what you're saying, comprehension is good. Then and then you can also, once you decide to do a spontaneous breathing trial, or you then think of extubation, of course then it comes that you can look for maybe cuff leak if you're thinking that there is a lot of laryngeal edema. Those things come later, but first is that patient is getting better, the pre-existing condition is no longer there, and these few things that we look for, and then you say, okay, that you can try and look for a segment of weaning.
I think ma'am will agree with all these things.
Yeah, I agree with whatever she has told. But also what we have to keep in mind here is if this patient has received steroids or required muscle relaxant at some point of time, you can expect that this patient is not going to be easy to wean. So we have to keep these things in mind when we decide to wean the patient.
Oh, and just one more thing, and if the patient is on vasopressors, they should be on like the smallest dose of vasopressors. Only then should you consider weaning.
Yeah. So this is very important because patient can die in critical care anytime. So if you do something wrong, it might not be to do with the antifungals or antibiotics. If you do something wrong in a supportive care as well, if you take a wrong call of extubating the patient who is not ready, there will be increased mortality. That is one of the reasons why you don't find difference between echinocandins and fluconazole in all-cause mortality. Yeah. So final question, this is very general question, but with the patient who is so sick, poor, malnourished, who wants to go home, the attenders wants to go home, and you know that the patient is improving, probably you need some more time. So how do you motivate the patient to survive or motivate the attenders to stay back in hospitals to treat for, how do you do it? Especially with kidney disease, you have a settled date and at least 2 to 4 weeks, patient will be on dialysis. So how do you counsel the patients? Because many of our patients, sometimes when I counsel, they go Dama. So I want to know, how do you do it?
So I think this is a situation, it basically depends on the finance. If there's money or you give a free treatment, he will stay. Otherwise, he won't. And so now we have this conservative kidney care, palliative people. So if this kind of situations, you can refer it to them, like you're telling Dharma. We try to avoid the Dharma nowadays. You can transfer them to a lesser, means you take a via media there. He need not be in ICU, you put him in the high dependency unit on oxygen. And this is a situation where whatever you do, the mortality is going to be high. I would say that this is a situation where maybe it could go as high as 80% mortality. So you're playing around with some 10-15%.
Sir. Varma sir, you call some people and you get somehow financial support from some NGO. How do you do that?
Yeah, again, as I said, it's all vitamin M game, right? M stands for money. That is a major deficiency in most of our ICUs. So I think way I look at this is we have to look at a patient in a holistic view, right? Because I remember when we were postgraduates, people were selling their house and trying to save their money and then try to save the patient, and ultimately patient dies, right? And along with that, family is in big trouble. I think when we counsel, I always take all those factors and how much shall we push. I think we have to be realistic to saying the patient, okay, he will survive. If you are not sure, you're giving a patient like this, pneumococcal septic shock, coming on 5th day with AKI, his probability of surviving, and you added a VAP to it in our ICUs, so chance is less and your finances are going to go up. So I think first we should be very clear, is this patient going to survive? Once we're there, then I think we have to talk to medical superintendent office, try to talk some people and try to arrange money. I think that is what is the driving force. The first step is the team understanding what is a prognosis, right? And the second important thing is I always consider is how is the patient party to you? Is aggressive, is trying to push you? Then I think you have to take one step backward. More you help them, more trouble you get into. That's all realities. I think we have to accept them. It might be different in a corporate hospital, it might be different in a university hospital, and completely different in a private practice.
Yeah.
Okay, during this discussion point, at one point, you have revealed the diagnosis as a culture report. It is yielded pneumococci, you have said. But after that, when the antibiotic panel was shown, there was no gram-positive coverage was not there. You can just go back to the slide. Antibiotics here. All those are covering this all are completely covering the gram-negative spectrum.
Sir.
Pneumococci is actually not covered in this one.
Yes, sir. So do you want to answer this question, sir?
Yeah. Microbial diagnosis was reached, but it was not addressed later.
Yes.
But this was at a different time point, right? So this is the patient who has sort of been treated for pneumococcus. It's been treated for pneumococcus, and then he sort of acquired something in the hospital. And in our ICU setup, 9 out of 10 times, it will be gram-negative. So that's the whole idea of covering that. So pneumococcus may not be there at present. That's why these are the options Dr. Praveen has given. So this is to treat the VAP.
Praveen, I have just
yeah,
one
ma'am. Yeah,
thing
sure.
left to say. With respect to maintaining the patient's zeal, of course, we spoke about every other thing. But if there are any postgraduates, undergraduates left behind now, I just wanted to say that this would be very important for those patients who are on non-invasive ventilation, who are awake, alert, and who can respond to you. Those are the patients in whom you can actually maintain zeal, give them some sort of confidence that this thing can be taken care of. Explain to them what the machine is going to do to them, what are they going to feel, how is it going to improve, and that helps the acceptance of NIV by the patient, and that helps overall treatment outcomes in patients who are on NIV. So with respect to zeal, I would really, NIV is a really, really important thing that we should look at.
Yeah. Thank you.
So just regarding the ID part of this, 99% of non-meningeal pneumococcal isolates are ceftriaxone sensitive.
Yeah.
So at the very least, we would like to narrow the spectrum from Miro to ceftriaxone. So at the very least, we could de-escalate from Miro to ceftriaxone. It kills as well as Miro, but it has lesser impact on the other flora, right? And if we do that, then there's a chance that the VAP that is developed may not be carba resistant.
Yeah.
By continuing with Miro, we are ensuring that we have to give poly-BTG, and there's no other option. And Miro covers strep pneumonia. So he has been covered for that. He doesn't require a vanco for that.
Completely agree with what you're saying.
Devashish, there's one problem with that. When we say VAP, right, it doesn't mean what antibiotic we have given has caused the drug resistance, right? It is the environment that causes most of the time, right? He would have acquired either way. Just because he's staying in our ICU or whichever ICU, he got it. It's not because you have given meropenem and he caused.
Sir, but I think you will be the first one to de-escalate.
No, but
so
while
I will
what you're saying
completely
is
agree
correct,
with
while what you're saying is
de-escalation
correct,
part. If the patient is having pneumococcal, we will obviously de-escalate. Yeah, if you are not de-escalating. So we agree with what you are saying. We would have probably de-escalated that patient, definitely. But the other part, patient would not have acquired carbapenem risk. I understand like exposure to carbapenem is one of the risk factor. But patients who are not exposed to any antibiotics are getting Acinetobacter VAP or Klebsiella VAP here. So I agree with what you are saying. We would have de-escalated. Yes, this was just for a discussion sake. Yeah.
Regarding that early versus late,
Yes,
one point I wanted to make, that actually we can predict whether a person is going to require. So we do a furosemide stress test. You have to give 1 milligram per kg furosemide, and if the urine output comes within the next 2 hours of 200 ml, that means he may not require dialysis. If it doesn't come, then next 2-3 days, the chance is that he may go in for stage 3 and require dialysis. That point I didn't make.
So there is a furosemide stress test which we can do. We don't have to call nephrologist for that. So that is something in the bedside which will help you. Yeah. Thank you.
We have come to the end of scientific sections for today.